Professor Lau, please.
Thank you, Professor Odif, and my dear colleagues, and thanks to President Professor Tanaka and Professor Omata inviting us to this meeting. And I think this is a small and beautiful meeting, and it's my honors to present some of our data, which we presented a couple of years ago, and I think we have a practical impact. The topics I'm going to discuss with you is HBV reactivations after DAAs therapies in chronic hepatitis C infected patients in an HBV endemic area. Well, since 2011, the paradigms of therapies for hepatitis C changed dramatically with the introductions of direct-acting antiviral agents. And we now, in 2019, the recommendations has all changed from the PR therapy rapidly into the pan-oral DAAs therapy. Well, a lot of these registration studies, phase 2, phase 3s, and they always exclude surface antigen positive patients. So to make things simple, and most of these studies are done in the US and European countries where there is a lot less of hepatitis B infected or co-infected patients like Mongolia. And one of the worry at that time is because it is dramatic with very short durations of therapy, a lot of patients being cured. It's very expensive. We have lots of debates and it changed everything, safety, efficacy, SVR12 definitions, and so on. And so it was included rapidly into all the guidelines. But it is very unconventional. We all need therapy. We all want one. But these types of DAAs therapies were never compared in the randomized control studies with PR therapies, for instance. And they also exclude some of the important elements of our characteristics of our patients who are also surface antigen positive. Being a APASL members and learning from this society and from our communities, especially from my Taiwan colleagues, we understand that both viruses can co-infect a single patient and they have interference. And I still remember I read the papers published by Professor Yun Fan Lao in 2003 in gastroenterology when he described the phenomenon of displacement of surface antigen positive patients in chronic hepatitis B patients if they are super infected with hepatitis C virus. So there are interactions. So I think that at that time, none of the studies was actually done in an HBV endemic patients or infected patients. But in this part of the world, which is represented by the Asia Pacific Associations for the Study of Liver Disease, we have lots of co-infections in this part of the world, not like the US and the European countries. We have 170 million chronic hepatitis C patients worldwide, 350 million chronic hepatitis B patients, and co-infections is estimated to be 3.2 to 12.8 million. Unfortunately, none of the registration studies with, I think there's 48 papers published in New England Journal of Medicine and Lancet and so on, or JAMA, they address these issues. So they all exclude surface antigen positive patients, and they never look into those patients with occult HBV infections. And I have alluded from our previous talks by some of the very excellent speakers, HBV reactivation is still a problem, and as a cause of acute liver failures or acute or chronic liver failures. And it's an important type of patients we are going to encounter as a practicing hepatologist in this area. Now, this is a table adopted from our journals, Hepatology International, published almost 10 years ago. So you can see here the co-infections rate of our different populations and countries in Asia Pacific regions. Say, for instance, in Taiwan, the co-infections rate is about 0.26 to 2.4%, and in China, estimated to be 0.6 to 1.74. And this is much lower in those countries where the DAAs registration studies is conducted, like the US and also the European countries, where the co-infection rate is only 0.09%. Now, having the opportunities to work in Beijing with my colleagues, and I'm stationed in Hong Kong and under one country and two systems, we have access to the DAAs earlier than mainland China. And one of the problems we are seeing in my Beijing hospital, together with my colleagues, we see a lot of hepatitis C patients, around 400 hepatitis C patients per day, and we have 5,000 hepatitis B patients per day. So we see a lot of co-infected patients, and with the introductions of the DAAs, lots of the patients were started on these therapies, treated in Hong Kong, and then follow up in Beijing under one country, two systems of the law, the basic law. We also take these opportunities at that time to really understand whether there is any reactivations or other phenomena in this cohort of patients. So we conduct and register the studies to prospectively collect 327 consecutive chronic hepatitis C patients, Chinese, treated with brand-named pan-orals DAAs in a prospective manner. And this is the tables being shown here, the flow charts of what was being done. And among them, 10 of the patients were surface antigen positive, and 317 patients were surface antigen negative. And we also defined occult infections as surface antigen negative HBV DNA positive by PCR, and we use real-time PCRs, and sensitivities is greater than 10 copies per mil. Now, this is we published the data later on, and within 2 weeks, the paper is actually accepted right away without revisions. And I think this is the happiest moment for our group. And what we observed is hepatitis due to HBV reactivations in surface antigen positive patients, chronic hepatitis C Chinese. And these are 3 subjects who suffered from hepatitis due to HBV reactivations. Because this is a prospective studies, so we measure the HBV DNAs and we characterize the sequence of events. Those patients who are surface antigen positive, also hepatitis C, and treated with DAAs therapy. And as you can see here, one of the patients suffered from the very serious fulminant hepatic failure, and he recovered with the prompt administrations of nucleoside analogs with entecavir. Now, we are not the only group who first described these phenomena, because we at that time think about the co-infections problems, and based on the interference studies, and we suspect this would happen. These reports are also reported in other areas, not just in China, in our centers, but also in places like Europe and also South Africa. Now, these hepatitis due to HBV reactivations does not only happen in surface antigen positive patients, it also happens in surface antigen negative patients with anti-core positive. And this table is the ones we adopted, and actually adopted by the FDA, which actually issues the black box warnings after further collections of these type of cases. Because of the registrations of these studies, they do not include surface antigen positive patients. This is the survival curves of our patients of 427 subjects. 10 of them are surface antigen positive, and those without surface antigen negative. So we also compare those with occult infections and without occult infections. And very importantly, you can see here the survival-free from hepatitis, survival-free in surface antigen positive, and it's very different. Occult infected patients does not really suffer from hepatitis due to HBV reactivations in those subjects treated with DAAs therapies. And it is, I think that the reactivations potential is much lower, and it's much less severe than those hepatitis due to HBV reactivations in other areas such as chemotherapy and so on. Concerning about this type of data of occult, it is very limited in the literature. Now, in the recent studies, our data were further confirmed by the German groups, who studies 822 subjects, German subjects with resolved HBV infections and following the DAAs therapies for hepatitis C for over 1 year. A total of 108 patients were followed up for a mean of 41.5 weeks after the end of treatment, and none of these patients suffered from reverse surface antigen seroconversions or reappearance of the HBV DNAs, signifying occult HBV infections co-infected with hepatitis C patients treated with DAAs is not really a very big problem. Well, this is the recommendations done by the FDA. It was unabashed soon after our publication, actually when our publication was accepted and was not published, and it is only online. And 2 weeks down the road, the AASLD issues the change of the guidelines, and then it is followed by the FDA based on 29 cases, including ours, and 2 deaths and 1 transplant. Very interestingly, I think that the occurrence of the hepatitis due to HBV reactivations, it happens in the initial periods of time, 4 to 8 weeks. Now, the recommendations at that time by the black box warnings is that all patients should be screened for the occurrence of prior HBV infections, and the baseline HBV DNA should be measured before the DAAs treatments. At that time, our groups did a meta-analysis and to compare with interferon-based therapies. And you can see here the pool incidence rates of hepatitis due to HBV reactivations is actually higher in DAAs treated patients than interferons, with a p-value of 0.09. And the onset of the HBV reactivations was also significantly earlier with DAAs therapies as compared to interferon therapies. In fact, the interferon-based therapies, we also observed the reactivations, but the mean time is around 42 weeks, but in DAAs it's only 8 weeks, and the p-value is very significant. So it's the timings of the reactivations, and I think that it's important as a hepatologist, when we treat patients with co-infections, we need to understand when what happens. Well, recently there's another systemic review. They collect more data and it's published in the Lancet GH by another group, which also shows that hepatitis due to HBV reactivations is a problem in those patients who are surface antigen positive with chronic hepatitis C infections. Because they have more data, they are also able to understand the importance of the HBV DNA levels and its impact on hepatitis due to HBV reactivations. As you can see here, those patients who have very low HBV DNAs have a significantly lower risk of hepatitis due to HBV reactivations in those co-infected patients treated with DAAs. How about the incidence of hepatitis due to HBV reactivations with DAAs in co-infected patients? I try to summarize the data available, published in the literature. In our groups, 3 out of 10 of these patients, surface antigen positives, suffers from reactivations. 1 has liver failures and 2 enteric hepatitis. All of the patients resolved. There are other reports in other parts of the world, New Zealand, Japan, and Taiwan, which shows a different incidence. But it is very difficult because of the definitions being used for hepatitis viral reactivations. What is the pathogenesis? From cell culture studies, there is no direct interference between hepatitis B and HCV's replication in the cell line. So it is not really the direct interactions. And probably the mechanisms behind is due to the normalizations of the hyperactive innate immunity response induced by hepatitis C infections, and with its normalizations, as its removal of the suppressions of hepatitis B, it leads to HBV reactivations. Now, so our postulated mechanisms of reactivations in these groups of patients is that HCV suppresses HBV replication via a hyperactive innate immunity response, and with the rapid suppressions of the hepatitis C by the DAAs, there's a normalization of these hyperactive states and results in the release of the replications and resulting in hepatitis and the liver failure. How to manage these patients? Well, I think that's we have alluded to. We still see a lot of hepatitis due to reactivations. We have lots of guidelines in those patients receiving immunosuppressive therapies, chemotherapies, liver transplantations, and so on, and also the rituximab in occult infections. But I think one thing lesson to learn is we have all the guidelines. All of them agrees we should screen for surface antigen positive and then the subsequent management. But I think simplicity is really the issues to go forward. Otherwise, our surgeons were going to miss all these reactivations. When we talk about two details about the levels of HBV DNAs should be involved, I mean, in the guidelines and so on, but it will be very difficult to implement. This is the most recent suggestions of how we manage these patients, HBV reactivations and DAAs errors. I think it is fundamental that we screen the surface antigen positivities in all patients hepatitis C treated with DAAs, and we should consider nucleoside analogs therapies for all surface antigen positive patients to make things simple, rather than measuring and monitoring and so on. And for occult, HBV infected patients probably is not a problem, but we will still monitor the liver function. Even if they have reactivations, it is not going to be too severe, and we should be able to salvage the problems. So last but not least, I would like to thank my team. I work closely with the hepatitis C centers in China, Beijing, and my groups in Hong Kong, Humanitarian Health, and also we have the Institute of Translational Hepatology to understand some of the immunological characteristics and the virological characteristics of these patients. And thanks again for inviting me to here to give the talk. Thank you.
Now is discussion time. Is there any question and comments in the floor? Professor Enomoto.
Thank you for a nice talk. I would like to confirm about the management of HBs antigen negative HBC antibody positive patients. In your last slide, or APASL 2016 guideline, only HBs antigen is the baseline testing. That is not included in HBC, anti-HBC positive testing patients. So, but in your last slide, if patient is HBs antigen negative, then you recommend that HB test for anti-HBC antibody. So, and then you recommended the monitoring of the patient. I feel that is not so simple.
Yeah,
so,
it's very complicated.
So,
yeah, because the Americans, they devise these DAAs and then they make a lot of money. That's all derived, but they ignore the co-infections. And we have the opportunity to study independently. Anti-core positive is obviously very important issues with occult. We see rituximab reactivations and so on. But for DAAs therapies, I think this is not potent enough to really cause the problems from the practical sense. Because if we devise too complicated guidelines like the Americans or the Europeans community, it's a cost. And it is very inconvenient. And then at the end of the day, it does not connect to the patients, because then it's all the sophistications. I think simplicity is something we should move forward. Especially now we are talking about multidisciplinary approach, a lot of the issues. And I think just checking the surface antigen, and if they are surface antigen positive, just treat. Because now is the nucleoside is all generics. It's so cheap from Korea, and we are using Korean's entecavir in our hospital authorities entire Hong Kong, and the price is only I think it's 40 cents per day, US dollars. So it's nothing now. So we are seeing different change of paradigms, and I think the guidelines for practical guidelines, if Professor Mata agree and Professor Tanaka is writing on this, we should be more practical
So how about the risk of the reactivation in anti-HBC positive patients and the management of these patients? Do you recommend that all of these patients should be treated with NA, with the DA? No?
No, I don't think it's potent enough to reactivate to this level. Because it is normalizations of the innate immunity control on the replications. It's not like the reactivation we see in chemotherapies with rituximab, with removal of the B cells and neutralizing antibody and so on. And from the German data just published, and it's actually support our series of patients, it's not a big problems. And if you bother to measure all the HBV DNA levels and so on, like the Americans are doing, it's not practical. Oh, and then in our area is all the generics, and it's cheaper and it's affordable. So why should we bother to complicate the whole issues, especially there are competitions, and then generics of the compounds of the DAAs itself. It's very complicated.
So we don't need to monitor or follow up the patient with anti-HBC positive but HBs antigen negative patients with the DAA.
Well, I don't
No
think.
need. No need.
I don't. Yeah, I don't think that's necessary.
Okay.
Yeah, that's my answer.
Is there any questions, comments? Okay, thank you very much for your nice talk, Professor Lau.